for running a measurement.
Test number 4 is going to be the toughest test you've ever taken in your entire life. Especially for Jonathan, because I'm going to give him a special test. But make no mistake, there's a lot to study and digest. So test number 4 is coming quick. We're 2 weeks away, I think. Right? 2 weeks from tonight. It's hard to believe. And I'll just tell you personally, you guys have been a great group to work with. I really love coming in here every night. And so kudos to you guys. And you make it a lot of fun for me. I mean, that's why I'm here. I'm here to have fun and see you guys get to the next stage of your careers. So I don't make that much money. You know, instructors get paid pretty well, but by the time Uncle Sam and the state are done with me, I won't say it's a freebie, but it hurts to see what the tax is. Okay, let's see. Pressure volume diagram due this Wednesday night. And there's a supplemental lecture, which I haven't recorded yet, but I will tomorrow. But there is a homework assignment. Anybody look at that homework assignment?
The Framingham assignment says that it's locked until today.
It says
It's locked. We weren't able to turn it in.
really?
It said it opened today, so I think you set it for it opening instead of it being due.
Better look at that. Just give me a second here. You guys spend half time talking one another.
But then Megan she did a bunch of the questions, so she'll have to send hers to Megan.
Did it?
See what other questions she didn't answer.
Okay, so what were you saying was locked?
The Framingham one said that it was available starting 5:30 May 6th, so today, instead of being due, so it was unlocked so it should be unlocked right now for everybody to submit it, but beforehand it wasn't.
Oh, wow, that's a good catch. Let's see here. You happy with that on me? Huh.
Was it Michael's car?
It's like we can all turn it in now, but
Yeah,
it wasn't
still.
available.
Huh, I do see that. It's, was supposed to click the do button, and instead there's a button below which says available from.
That's probably like the hardest part
Okay,
about it.
all right.
Everything else is pretty easy.
Here we go.
It's not like
Does everybody have their Framingham study done?
Yes.
Everybody. There's nobody that doesn't have it done. Okay, go ahead and submit it, if you haven't already. Let's see here, I'm gonna make it due at 10 p.m. tonight. That way everybody's got plenty of time to submit it if they haven't already. Okay. All right. Back on track now.
Where? Actually, can you just take like a screenshot of this?
So here's this file that was posted earlier today. And what I've done in this is I've tried to break out key bits of data that you've learned throughout the semester. So for instance, in blood chemistry, what would you expect the concentrations of our 4 key ions to be? And there they are, right there. And we've used those all throughout the semester. The pH for arterial blood is 7.4. That's a standard textbook value. Slightly alkalotic. Key metabolites in the blood, well, the one that's of most importance, at least to me, and hopefully to you also, is glucose. And so all of you, that's interesting, that's not right. Let's but 100 milligrams per 100 milliliters. So just write this down. I'll repost this, but make sure that that's corrected. Concentration, hemoglobin in the blood, 15 grams per 100 milliliters of blood. That's just a nice round number to use. It's typical of usually men, that's kind of the average value. For women, it's slightly less, but 15 is a nice round number. Percent saturation of hemoglobin under normoxic conditions is greater than or equal to 97%. So in your arterial blood, we're expecting percent saturation hemoglobin to be 97%. Hematocrit, again, just a good round number for a textbook value, 45%. That's the relative proportion of red blood cells within a given volume of blood. Key lipids, total cholesterol, 225 milligrams per 100 mLs. If you go out there, you'll find variations on this depending upon age, depending upon sex. It's slightly different, but for both men and women, 225 is a very reasonable average total cholesterol value. For HDL, again, an average mean value, a decent value is 50 milligrams per 100 milliliters. So of that 225 milligrams, about 1/5, 1/4 of your cholesterol should be in the good form. There's the bad form. So if you don't know this already, LDL is the bad form. This is the form that's involved in the production of plaque within the lumen of coronary arteries. And the average is 130 over 140. Listen carefully. The American Heart Association wants everybody to be below 100. So if you went and had your blood chemistry done today, and let's say you're at 150, hopefully your doctor sit and say, you know what, we need to get you down a little bit lower. And maybe if you increase your physical activity, that'll do it. But that's what all of you should be shooting for. LDL is highly correlated to the development of coronary artery disease, and less than 100 is the recommendation by the American Heart Association. Blood gases, PaO2 of 100 millimeters of mercury, partial pressure of arterial CO2, 40 millimeters of mercury, partial pressure of venous O2, 40 millimeters of mercury, partial pressure of, this should be venous, not arterial, I'll correct that. Venous CO2 is greater than 48 millimeters of mercury. Partial pressure of mitochondrial O2 less than 8 millimeters of mercury. The partial pressure of mitochondrial CO2 greater than 48 millimeters of mercury. The oxygen content of the blood, and here you can put an approximation symbol there. Should be right around 20 milliliters of O2 per 100 milliliters of blood. Please make sure you know all the units so that if you're asked to do a calculation, you've got it. Respiratory measurements. Normal value for breathing frequency is 12 to 18 breaths per minute. Typically, individuals will use 15. Typical value for tidal volume is 500 milliliters per breath. A typical value for the anatomical dead space is 150 milliliters per breath. Here, I've got V subscript capital A. That's the alveolar volume, 350 milliliters per breath. Then I've written expired minute ventilation rate. The symbol for this is V dot subscript capital E. So write that in one of your notes if you got it. So expired minute ventilation is V dot, capital V with a dot above it, and then subscript capital E. And that's simply read as expired minute ventilation rate. And a normal value is about 7,500 milliliters per minute. How did I get that? Well, if you take a look at these values for respiratory measurements, a few moments ago I said that a typical value for breathing frequency is 15 breaths per minute. And a typical tidal volume per breath is 500 milliliters per breath. If you multiply these two, the product is 7,500 milliliters per minute. But, remember, we're not interested in the expired minute ventilation rate. We're interested in the alveolar ventilation rate. And so the alveolar ventilation rate is the tidal volume minus the dead space volume times the breathing frequency. And in this case, using a breathing frequency of 15 breaths per minute and a alveolar volume of 350 milliliters per breath, that gives us an alveolar ventilation rate of 5,000 milliliters per minute. FiO2. FiO2 is the fraction of inspired oxygen. Previously, I told you that the air that we breathe in the lungs has 20%, 21% of it is oxygen. So if we write that as a fraction or decimal, then you would write it as simply 0.2093. The fraction of expired O2 under resting conditions is right around about 17 to 18%, or written as a decimal, 0.18. The resting oxygen uptake. If you take a look at the screen there, I've got resting rate of oxygen uptake, and I've got, this is a rate. So in Word, I can't put a dot above it, but now you're gonna put a dot above that V, right? Right here. So right above this V, you're gonna put a dot there. And then that's V dot O2 is read simply as the rate of oxygen uptake. Here's another measurement that we've talked about, and that is VAQ ratios. Now really it should be V dot subscript A, so put a dot above that V here, because that's the alveolar ventilation rate divided by, and put a dot above the Q, because that's cardiac output. So V, this is, we don't read the dots, we simply read it as a VAQ ratio, but it is V dot A and Q dot. And you'll notice that I wrote that a typical VAQ ratio is 1. I'll come back to that in a moment. Cardiovascular measurements. Well, for the heart, we've got heart rate is the range, the normal range is 60 to 100 beats per minute. Typically, people tend to use a value of 70 in doing calculations for a resting state. Stroke volume. Well, our textbook value is 70 milliliters per beat. EDV, our textbook value is 120 milliliters of blood. Our textbook value for end systolic volume is 50 milliliters of blood. The cardiac output, our standard textbook value, you can read just about any textbook, and it's going to tell you that a standard value for cardiac output under resting conditions is 5 liters per minute. And in this case, I simply wrote that in units of milliliters, so 5,000 milliliters of blood per minute. And the ejection fraction is simply the amount of blood, it's the stroke volume divided by the end diastolic volume. So write that in your notes. The ejection fraction is the amount of blood pumped out per cardiac cycle expressed as a percentage of the end diastolic volume. So, using that definition, if you take a look at our normative data, our normative value for stroke volume is 70 milliliters per beat. And our normal value for EDV is 120 milliliters of blood. So what is 70 divided by 120? Can anybody do the math for me quickly?
65?
Yeah, right about that. And so the normal range for ejection fraction is somewhere between 50 to 65%. And you notice I have it written that the ejection fraction is 50 to 65% of EDV. Blood pressure. Blood pressure, so I have values for both men and women. So for women, I've stated that our textbook value for a blood pressure would be 110/70. So that would be the systolic over the diastolic. And for men, the textbook value is 120 millimeters of mercury over 80 millimeters of mercury. I gave you a formula last week to calculate the mean arterial pressure. I'll come back to that in a moment. And the mean arterial pressure for women is typically right around 83 millimeters of mercury. For men, it's right around 93 millimeters of mercury. And the normal range is about 70 to 100 millimeters of mercury. Anyways, when you leave here in 2 weeks, you'll have this little laundry list of important clinical data. And for those of you who go off into PA school, nurse practitioner, nursing school, take that list with you because you're going to bump into it often. Well, now as part of all this kind of sets the backdrop for a set of questions. So here's a set of homework, a set of questions. I believe I've got the set to be due next Wednesday night. So first off, it says in each of these problems, make sure you show any important calculations. Well, it should just say, make sure you show your calculations. So number one, you have a patient who has the following blood chemistry values. I'm not going to read all those. Their EKG looks a little off. Well, there's EKG. Based upon their EKG and blood chemistry data, what do you think's going on? And I'm not interested in just you telling me if there's something abnormal with EKG. I'm interested in you explaining the abnormality of the EKG based upon the data that's presented up above. Everybody with me on that? Second question. You have a patient who presents with the following data, and then there's this little laundry list of data. I don't know about you, but I took this guy's class before, and he's a hard ass. And is it possible that on test number 4, all these data are going to show up in different forms? Yeah, I only took this class 5 times before I finally passed it, so be prepared. Anyways, here's number 2, and then there's this curve down here.
What do you mean by different forms?
Huh?
What do you mean by different forms? Just like...
Things can change in this world, just like a real patient. I had a student who went to the department chair, this is many years ago, and she goes, he asks these questions where there's more than one right answer. Department chair says, just like what I said. You're going to nursing school, right? Yeah. What do you guys all expect, that there's only going to be one possibility for every patient? That's every patient you see is a quiz, right? That's a quiz question staring you in the face. Is there only one correct answer? Mr. Tom, the patients that show up in your office, is there only one correct answer? No. Yeah, and I'll just tell you right now, and I don't care what part of medicine you're in, and I say this having been involved in classes that use a lot of patient data. Taking a good history is really, really important in medicine. Don't ever minimize the importance of a good history. And all the shtick in medicine is creating what's called a differential diagnosis. You take all the laboratory data, you take your patient data, their history, and you put it all together, and you start making a priority list. It could be this, A, or B, or C. I'm 80% sure it's A, that's where I'm going to spend most of my effort, but if it's not, I've got these 2 other alternative possibilities. That's a differential diagnosis, and that's how that game is played. In essence, you guys are going to be human biology detectives. Sounds pretty cool to me. Question number 3. Using the normal values, the normal values presented up above, calculate the oxygen uptake rate as determined using respiratory measurements. Number 4, calculate the oxygen uptake rate of a normal person at rest using the Fick principle. Fick principle. Have you guys heard of the Fick principle? No, you haven't. You've heard of fixed law of diffusion, but you haven't heard of the Fick principle yet. Question number 5, calculate the mean arterial pressure for Mrs. Jones using the following data. Here's an interesting one. Based upon the following information, determine the stroke volume and ejection fraction. Number 7, using the algorithm for the determinants of cardiac output, how would propranolol affect the shape of the pressure volume diagram? How would this influence the work performed by the left ventricle? And how would this influence the oxygen requirements of the left ventricle? Mr. Tal, what's your knee-jerk reaction?
Well, with beta blockers, they're going to decrease the heart rate and decrease stroke volume. So as far as oxygen requirements go, I don't think the heart would require as much oxygen.
Okay, should go study with him on that one. But there's a lot more to that question than meets the eye, right? Number 8, using the algorithm for the determinants of cardiac output, how would left AV valve stenosis impact the shape of the pressure volume curve for the left ventricle? Anyways, those will get you thinking. Due next Wednesday night. All right. Okay, let's see here. All right, so I want to come to the regulation of blood pressure because that's part of our diagram over there. So we're going to talk about the mean arterial blood pressure, which I've already mentioned to you before. I do want to define for you what's called pulse pressure. That's an important clinical term to deal with. We're going to rework Ohm's law. We're going to talk about the hydrodynamics of blood flow, taking Ohm's law and rewriting it as Poiseuille's law. We'll talk about calculating the mean arterial pressure. You can see here I've got in the outline that our normal range for math is 70 to 100 millimeters of mercury, which I mentioned just a few moments ago. And then I do want to talk to you about the importance of mean arterial pressure in terms of its in terms of how it affects the perfusion of tissues. And then we'll talk about short and long-term regulation of mean arterial pressure. In doing that, I'm going to put up a negative feedback loop, and it turns out that there are these pressure sensors, and the pressure sensors are found within the carotid body. So if you recall, when I talked about the regulation of ventilation, I mentioned that within the carotid bodies, in the carotid arteries, there are chemoreceptors. Well, also there are pressure sensors there, and we refer to those as baroreceptors. That first part, baro, means pressure. So pressure sensors. So the primary pressure sensors or baroreceptors are in the carotid bodies. There also are baroreceptors located in the aortic arch. That's good. Sit there and think about that. That both of those are proximal to the heart, and they're proximal to the main vessel responsible for the delivery of blood to the brain. And these depend upon stretch-activated ion channels. And that's that for right now. So let's come back to that, and we'll turn our attention now to our diagram out over there. A couple things to emphasize for you is that we've already talked about the different factors that determine end diastolic volume and end systolic volume. Importantly, this is the passive side. Here, the ventricle is filling up. So make sure that in your mind, in terms of sitting there and thinking about the mechanics of the heart, that on the EDV side, you understand that since this is the filling of the ventricle, it's all passive over there. And what I'm getting at is under stiffness. So stiffness is simply the relationship or the dependence of passive forces on length. So when we talk about stiffness, we're plotting force on the y-axis and length on the x-axis. And the slope of this relationship is stiffness. And you'll notice that I wrote up there, passive mechanical property. Stiffness is a passive mechanical property. And let me rephrase it, it's a passive elastic mechanical property. In contrast, on ESV side is not the passive side, it's the active side. And so, in talking about afterload or the diastolic blood pressure, I told you that this is where the force-velocity relationship comes into play. And the force-velocity relationship is dependent upon the number of sarcomeres in parallel and the type of myosin. That's the force-velocity relationship, and that is an active mechanical property. And then we've got the Frank-Starling mechanism. And the Frank-Starling mechanism, all of you would tell me that the underlying basis to the Frank-Starling mechanism is a length-tension relationship. And this also is an active mechanical property of muscle. Questions about that? If I confuse you with that, don't be bashful, speak up. All right. So everybody should appreciate that Q dot this is really, so in Ohm's law, F is really Q dot. That's the flow rate. So we want to think about our mean arterial pressure because mean arterial pressure is the driving force. It's the pushing force that determines perfusion of the tissues. And by definition, if pressure goes down, then the flow rate through a tissue bed is going to go down. Up above here, I'm going to put T, P, R. That stands for total peripheral resistance. So here I'm going to just write M, A, P divided by T, P, R. And now I'm simply going to rewrite this equation and solve for mean arterial pressure. And so we're taking this simple, basic formula called Ohm's law, and we're applying it to how the heart works. And so now here's a way to really connect the dots, hopefully for you, is that rather than just sitting there thinking about this, trying to be more explicit, and rewrite it with regards to our algorithm over there. So our formula for the mean arterial pressure is as follows. So mean arterial pressure is equal to the diastolic blood pressure plus the quantity of 1/3 the difference between the systolic blood pressure minus the diastolic blood pressure. And we did the calculations last week, right? I can't remember. Did we do that in lab or did we do that in here? Anyways, we've already talked about that a little bit earlier, but for women, the mean arterial pressure is a little bit lower than it is for men. Not much, but a little bit lower. And as I stated earlier, the typical range is about 70 to 100 millimeters of mercury. Yeah, I told you guys a story about this guy that worked for me who's having a heart attack? Yeah, no, maybe so. Nobody remembers it? Ended up having a heart attack in the emergency room. Nobody remembers that either. Gosh, you guys don't remember anything I say. I'm really depressed. Anybody didn't say it? I think I did though. I had this guy who worked for me, ex-merchant Marine, about 40 some odd years of age. His typical blood pressure was 140/90. He comes in, he says, hey, I'm not feeling right. I'm looking at him. His face is turning white on me as I'm talking to him. I take his blood pressure, it's like 110/60. You know, I'm sitting there and I'm looking at him and he's going, he goes, I feel really bad. I go, make sure you're lying down. So we get him lying down, take his blood pressure again. It's 90/about 50. What's his mean arterial pressure? I need you guys to figure that out for me. Go ahead. I'll give you a minute. 90/50. All right, time's up. You guys ready? Or did you want me to do that?
No, I got it.
Okay, you got it, all right.
I got 63.3.
63? What do you guys think? That's what I got. 63. Here's a question for you. What's responsible for producing the pressure in the circulatory system? Let me ask Philip. Philip, what's responsible for producing the pressure in the circulatory system?
Filling pressure?
Well, what's responsible for producing filling pressure?
Blood volume?
You like those four things right there?
I don't know. Let me ask my question again. Stephen, what are you gonna tell me? What's responsible for producing the pressure in the circulatory system?
Systolic blood pressure.
Okay, all right, let's see here. Ms. Rodriguez, good evening. What's responsible for producing the pressure in the circulatory system?
The flow rate, cardiac output,
What's responsible for producing cardiac output?
the heart.
Bingo, there we go. That's right. Here's the logic, guys, right? Is that the question is, what's responsible for producing the pressure in the circulatory system? The answer is the heart. Okay, our pressure has dropped. This is an individual whose mean arterial pressure is normally up around 95, and all of a sudden he's at 63. What does that tell us about the heart? Its ability to produce pressure. It's going down. Why? Because the heart's being starved of oxygen. And we got a big problem on our hands, right? Okay, so now let's come back, or let's come to this issue of total peripheral resistance. Now, remember, the arteries and the arterioles are the resistance side of our diagram, right? Remember, I've shown you that. Is that veins and venules are the capacitance side. They have this capacity to really dilate tremendously and impact cardiac function. But the resistance side is the artery and arterioles. Those are our resistance vessels. And if the smooth muscles and the arterioles contract, then you're going to tell me resistance is going to go up, 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 up. Absolutely. Okay. So here's Ohm's law. And that simply says that flow rate is equal to delta T divided by R. But that is a really gross simplification. And so we need something that's more insightful. And this something more is known as Poiseuille's law. I'm going to use Q dot for flow rate. So Poiseuille's law says that the flow rate, Q dot, is equal to delta P. Wow, that almost looks like Ohm's law, except it's equal to delta P times pi times R to the 4th divided by 8, just the number 8, N L. Okay, so R, what is R? This is the radius of the lumen. Listen carefully. We could apply that to anything. We could apply that to the airways of the lungs. We could apply this to the blood vessels of the circulatory system. So Poiseuille's law is not just specific to the cardiovascular system. So R is the radius of the lumen. N is the viscosity. In this case, we're going to say of the fluid. It could be the gas as well. And what is viscosity? Luis, what would you tell me? What is viscosity? it again?
How well something can flow.
How well something can flow, okay. Anybody have a definition of viscosity?
How slow the fluid moves.
How what?
Uh,
Well, I don't know if any of you ever put oil in your cars, but if you go buy oil, you'll see that oil is sold based upon weight. So maybe a 540, 1040, that 1040, that tells you that when that oil heats up, its viscosity changes to a lighter weight, and that means it's less viscous. Viscosity, the thickness, and viscosity really is, the more viscous something is, the more thick something is, the more difficult it is to push it through some type of a tube. So your oil goes 540, let's say. When the oil's cold, then the oil is thick. And when it warms up, it changes its viscosity, becomes lower viscosity. In the old days, in the dinosaur ages when I grew up, you just bought them as a single weight. You buy 40 weight oil. So viscosity. This is the thickness of the fluid, a measure of the thickness of the fluid. And L is simply the length of the tube. Well, in the circulatory system, what we're really talking about is the length of an artery or the length of an arteriole. Miss Amanda, we come along and we double the length of a tube. What's going to happen to flow rate?
Cut in half.
It'll be cut in half, that's exactly right. Let's say, Amanda, that we double the viscosity. What would you tell me would happen to the flow rate?
Also cuts it in half.
It would, that's exactly right. What if we came along and we doubled the pressure?
Then we double flow rate.
We double flow rate. And what would happen if our radius dilated twofold?
16-fold for...
16-fold change. So radius is a huge factor in determining the resistance. Huge factor. And as radius goes up, resistance goes down. And not by a little bit, but by a lot. So remember, we can come along and we can rewrite this equation to solve for pressure. So we would have delta P is equal to Q dot times eight NL over pi R to the fourth. So this term is resistance. So folks, radius is incredibly powerful in terms of its impact on flow rate or pressure. Incredibly powerful. So if I want to increase the flow rate by 50%, I just need to produce a small change in radius. I don't need to have a twofold change or even 100% change. I just need to produce a small change in the radius, and because it's R to the fourth, I'm going to get this huge exponential consequence that will really impact pressure or flow rate, depending upon what we're trying to solve for. But here, for us, we're talking about mean arterial pressure, and the total peripheral resistance is dependent upon Poiseuille's law. You could tell me Ohm's law, but if you write Ohm's law, you're missing the point, because this radius is such an important factor. And make sure you understand that when I'm talking about blood vessels, we're talking about arterioles and arteries. But arterioles are really the resistance vessels of the circulatory system. Yes. Yes, 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 yes. I forgot to put something in here, so darn important. Smooth muscle cells, oh yeah. Mr. Vadi, smooth muscle cells. I forget, how do we control smooth muscle cells?
Neurologically? So neurologically?
Okay, so why are you making faces at me?
There's three ways, right?
There's myogenic,
Neurogenic,
there's neurogenic,
chemogenic,
chemogenic. And we're talking about neurogenic. Help me out there because my memory is faded on me quickly.
so with
ACH? Got that cough tonight. I can't remember that diagram. Steven, maybe you can help me out. Do you remember that diagram?
Well, you want me to go through all of them?
Well, let's maybe start off with alpha-1 adrenergic receptors, just coming off the top of my head here.
Oh, no.
He was kind of calling my bluff, you know, like, yeah, he doesn't know, he doesn't remember this. That guy's getting pretty old up there.
Alpha-1 to phospholipase C would result in an increase of IP3,
Oh, good.
which would result in an increase of myosin
Which will result in an increase of calcium bound to troponin C, right?
no,
Darn it, he didn't let me go down that road. To tropomyosin.
no,
To what?
to myosin light chain kinase.
To
Activity.
calmodulin, did you say?
Oh, maybe.
Yeah, maybe. I think I heard him say calcium will bind to calmodulin, and then calcium bound to calmodulin, that calmodulin is gonna act on this enzyme known as,
Myosin light chain kinase,
bingo, which then leads to the what?
which leads to phosphorylation of regulatory myosin light chains.
Good. That then turns on our molecular motor, and that smooth muscle cell now contracts, and the lumen of our arteriole is going to get,
Smaller?
it is going to get smaller, that's exactly right. Yeah. That's exactly right. Good job. Well, so as it turns out, you know, we talked about blood pressure last week. And so, if you recall, we talked about using calcium channel blockers to help with blood pressure. Also talked about using beta blockers to help with blood pressure. But there's a totally different strategy, and that strategy is not to act on the heart itself, but to come over here and to pharmacologically manipulate the smooth muscle cells that make up the tunica media of the arterioles. And so what can we do here? And the answer is we can use alpha-1 blocker. And here's the name for you. Doxazosin. This is a alpha-1 blocker, and I'll say a very powerful blocker that will produce remarkable decreases in blood pressure. The problem is most patients do not tolerate these alpha-1 blockers very well, and so they're not a frontline medication that's used to treat blood pressure. Treating blood pressure goes for something I haven't described yet. Frontline blood pressure. What else besides what we've talked about up here? Alpha blockers, calcium channel blockers, beta blockers. There's something that doesn't target any of those. It targets the lungs. What is it? Don't know? It's okay if you don't know. Okay, no harm, no foul. They're what are called ACE inhibitors, a really important class of drugs. And what you're going to learn beginning Wednesday night is that these ACE inhibitors act on a really important enzyme that converts angiotensin 1 to angiotensin 2. And so, interestingly enough, these ACE inhibitors attack an enzyme in the lung known as angiotensin converting enzymes. Anyways, a very, very powerful way to go. So there's lots of other things coming. We've got the lungs, we've got the kidneys. The kidneys, a lot of room there for pharmacological treatment of blood pressure. Okay, so now in this diagram, you need to make sure that you've got all your calcium channel blockers in hand, you've got your beta blockers, you've got our cardiac glycosides, which are being used to improve cardiac output, and we've got our alpha blockers, our alpha-1 blockers that are acting on the smooth muscle cells of arterioles, and here's the name of the drug you're going to need to know as the alpha-1 blocker. Questions? Don't be bashful, speak up. Going once. Going twice.
Cardiac glycoside is what again? Sorry, is that in relation to?
Like wabane, digitalis, digoxin, those are cardiac glycosides. Those inhibit the sodium, potassium, ATPase pump.
Okay. Thank you.
All right. Let's talk about, I'm gonna do this in blue. I apologize for you, to you in the back there, you won't be able to see the blue, but let's talk about the autonomic control of the heart. Because if you recall, there was that table that we developed, we're talking about contrasting skeletal, smooth, and cardiac muscle. And one of the points I made to you is that skeletal muscle is controlled by the alpha motor neurons. The heart is controlled by the autonomic nervous system, and there we have to think about the parasympathetic and the sympathetic branches of the autonomic nervous system. So here I'm going to put a little arrow, and I'm going to just put para, P-A-R-A, and you're going to understand that what I really mean is the parasympathetic branch of the autonomic nervous system. And in front of that, I'm going to put a negative sign. And what I mean by that is that parasympathetic stimulation of the heart is going to cause heart rate to go down. I'm also going to put S, Y, M, P, A, T, H here, sympathetic. And of course there I'm going to put a plus sign. So if we increase sympathetic stimulation of the heart, we're going to cause heart rate to go up. How about over here? Where in the system is the sympathetic nervous system? The answer is right here. So here I'm going to put underneath number 2, where I've got beta 1 adrenergic receptors, I'm just going to put S, Y, M, P, A, T, H. And you'll understand, hopefully, that if we increase sympathetic activity of the heart, we're going to cause the atria and the ventricles to contract with more force. Make sure you got that written down. So the sympathetic branch of the autonomic nervous system is controlling the contractility of atrial and ventricular cardiac muscle. Well, hopefully, you might sit there and say, well, what about parasympathetic branch? Where's that over here? And the answer is it's not. So the parasympathetic is only driving heart rate, is only controlling heart rate, and it's causing heart rate to go down. Sympathetic stimulation is doing two things. It's causing heart rate to go up, and it's causing the chambers of the heart to contract with more force. So now in that diagram, you have information related to different pharmacological strategies that can be used, and also now we've incorporated where the autonomic nervous system feeds into our algorithm. And here, let me just put, to be consistent, and here I'm just going to put a positive sign here. Questions? Take a pause. Questions. Don't be bashful. Speak up. Nobody wants to say anything?
So with the drugs, do you just want us to, like, for the test, just understand that they're like alpha-1 blockers, or like the relationship here? Do you want us to memorize the names of all of the drugs or what?
Yes.
Okay.
Hopefully that was obvious. Yeah, I didn't give those names out just for the heck of it. Yeah. So if you show up for the test and I talk about carvedilol, you're going to sit there and say carvedilol is an ACE inhibitor. No, you're not. But, you know, from my perspective, what's kind of cool is that you get to learn a little bit of pharmacology and how pharmacology can play an important role. And we're not talking about pharmacological treatment of tics of the eye. Remember, blood pressure is the silent killer. It's responsible for 30 to 50% of all strokes, on top of a large portion of heart attacks. So blood pressure is incredibly important. Not to be trivialized. All right, let's talk about orthostatic tolerance. And in doing that, we're going to talk about a negative feedback loop for the regulation of mean arterial pressure. So I just keep saying this ad nauseum, is that whenever we talk about negative feedback loops, you're going to sit there and say that there is some type of a controlled system. And in this story, it's our mean arterial pressure that's the controlled system. And anytime we're talking about any feedback loop, there are always our sensors. And importantly for this story, there are these peripheral baroreceptors. So we're going to talk about baroreceptors. And the key baroreceptors, as I mentioned before, are the carotid bodies, the aortic arch, and just as a little heads up, we're going to put in here renal baroreceptors. Renal. This is kind of cool. So beginning Wednesday night, or actually beginning tonight, you're going to learn that your kidneys play an incredible role in regulating blood pressure. And here's how they do it, which I think is pretty awesome, is that they control your blood volume. Sit there and think about that. Is that when you go to the restroom, number one, what are you doing? You're offloading some of your blood volume. That's what you're doing. So if you sit there and think about drinking a lot of fluid, which some of you are going to do Wednesday night, where does all that fluid go? So it goes into your gut and it's absorbed into the circulatory system. And now the volume of blood in the circulatory system has gone up. So the kidneys are going to see that, and they're going to sit there and say, you know what? We've got to get that volume down. How they do that? By excreting more of the filtrate. In other words, increasing your urine volume. And that gets blood volume back down to where it needs to be. It's pretty amazing. So the kidneys are a huge part of this story. Well, we always have to have our set points. And here the set point is mean arterial pressure that's between 70 to 100 millimeters of mercury. Folks, make sure you know your units. There were some of you on the last test. It kind of killed me to grade your answers wrong. But some of you had the wrong units. You know, and instead of having the right units, you had the wrong units. You actually did the calculation, you came up with a number that was right, but the units were wrong. And so make sure that you always end up with the right units. Okay, so the sensor is looking at information coming from the control system, comparing it to the set point, and then this is fed to the so-called inverted amplifier. And here that inverted amplifier is the autonomic nervous system. And we can control our pressure by altering heart rate and also stroke volume. These diagrams are all connected to one another. So here's a scenario. We've got Mrs. Jones. She's been in the hospital now for 3 weeks. We're having a terrible time getting her out of the hospital. And it's time to try to get her up and walking. So she's been in bed rest for quite a while. And we come along and we sit her up. And she starts to turn white on us. And she says, hey, I don't feel right. So what's going on with that? In this particular case, what's happening is due to an increase in the effect of gravity. Her mean arterial pressure is going down. Right? So we're over here. Here's how you need to answer this or think about this. The effect of gravity has gone up. What that means is that the filling pressure is going to go down. If you still are having difficulty with that, the way I think it's simple to sit there and think about the fact that the heart has to produce enough energy to lift this fluid column back up to the heart to fill it up again. And if it's using a lot of that energy just lifting the blood up, that means that there's less energy available to create a filling pressure. And so as we increase the length of this column that the heart has to work against, we're increasing the energy that we're basically using up just to lift the blood, which means the energy left over to fill up the heart is going down. And that's what's happening in this instance here. So we've got this decrease in mean arterial pressure. Well, the baroreceptors in the carotid bodies are sitting there seeing this, and they're communicating with the brain to the so-called vasomotor control center of the brain, and sitting there saying, hey, look, pressure's going down, and so that communication is going to activate the sympathetic branch of the autonomic nervous system. So these are our primary baroreceptors right here. The aortic arch is important, but it's the carotid bodies that are most important. So in this case, what we're going to do is, as I said, we're going to communicate with the vasomotor control center of the brain, and what we're going to do is we're going to increase sympathetic stimulation. This is going to cause an increase in heart rate. And we're going to come along and we're going to release more norepinephrine onto the heart, causing more calcium to come into the cardiac myocytes, to cause more calcium bound to troponin C, to cause more myosin molecules attaching and producing force, so the heart's going to be able to contract with more force. And this is going to cause our end systolic volume to go up because force is going up. What do you think, Mr. Lou, is that correct?
Would it go down?
I don't know, I'm asking you, because if the heart is contracting with more force, is it going to squeeze more blood out or less blood?
Squeeze more blood.
That's correct. And so ESV is going to go,
Should go up, right? Up?
so remember, this is the logic part of this game, right? Is that the end systolic volume is the volume of blood left in the ventricle at the end of systole. So if the heart's contracting with more force, it's going to push more blood out, and therefore at the end of systole there's going to be less blood left in the ventricle. So ESV is going to go down, right? So ESV is going to go down. We're also going to increase heart rate. And so we've got now an increase in heart rate. We've got an increase in stroke volume. That's going to cause cardiac output to go up. And here's our beautiful little equation. Solving for mean arterial pressure. And that's going to cause MAP to go, what's it going to do? So wait a minute, we got Mrs. Jones though. She's got a decrease in filling pressure. So the way we counteract this is, as I'm describing for you, is we've got to decrease our end systolic volume, which is going to lead to an increase in stroke volume, right? Yeah. So let me just rewrite this a little bit differently. So we're going to have an increase in stroke volume, and that's going to come about due to a decrease in end systolic volume. This leads to an increase in cardiac output, which will then lead to an increase in mean arterial pressure. So that's how the system should operate. With her, because she's been in bed rest for so long, it's not operating the way it should, because the system has changed its set point. So our physiological systems are not absolutely hardwired. They're pliable, they're malleable. When we expose the carotid bodies to high levels of CO2 because of emphysema, guess what? They adapt and they sit there and say, you know what? We're going to change our set point from a PaCO2 40 millimeters of mercury to 46 millimeters of mercury. Now that doesn't work so well for the system, right? Because now you're less sensitive to CO2. In this case, what's happened is that we've had an individual who's been lying down, and so that's what they're accustomed to. The heart has kind of, its adaptation has been negative, so that when we try to sit them up, they pass out on us. The astronauts, sometimes they have a tough time when they come back from a micro-G environment into a 1G environment. If you look at all the Russian cosmonauts that come back, they don't have them standing up when they land. They're sitting in a recumbent position. It's because of these types of things here. All right. That's it for tonight. So we're done for tonight. When we come back on Wednesday night, I'm going to come back and I'm going to talk about the Fick principle. That's an important thing for you to know. And then we'll transition into the renal physiology. So with that, I'll see you guys Wednesday. Study hard. Do not